Hey, Sean. Hey, Sean, how are you? Hey, Lori. Hey, Sean, how are you?
Doing good. How are you, Tony?
I'm good. You staying out of trouble?
Yeah. You know me.
That's why I had to ask the question.
Trying to.
I'll just say hello. Thank you for welcoming me.
Hey, look, how are you doing, Lori? You good? You gonna be on camera or no camera?
If I do camera, I have to sit like this, so I'll not do a camera. But nice to meet you, and looking forward to hearing what you guys have to share today.
Not a lot. Don't worry. It'll be like.
So, are you in West Virginia?
I am. I'm in Hardy County. Where are you?
I'm in Oklahoma.
Oh, okay.
Just people sing that song to us all the time.
I almost did it, but I stopped myself.
No, it's a tradition. That's a traditional greeting.
There's because there's two Amy's. There's Amy Snodgrass and another Amy from the health department here. And so they always sing the Amy song, and I'm sure they're tired of it. So, hey Tom. Hey Tom, welcome to the party.
Hello there, how are you all?
I'm good. We're gonna have fun today, right, Tom?
Of course.
We're gonna relax. We're gonna have fun. We're gonna, as the kids say, are you ready, Tom? I'm getting ready to teach you. We're gonna chop it up.
Okay, that's a new one. Okay.
Okay, we're gonna chop it up, Tom.
Okay.
All right. Okay.
I'll trust you to guide me.
Don't, and that could be a road to, that could be a whole bunch of not good intentions. Now, we had 100, so you'll know, we had about 100, and I think Marcus told me 120 people who registered for this. So that's the good news. So we're gonna, let everybody sign in, and then we're gonna, what are we gonna do, Tom?
Chop it up.
We're gonna chop it up. There you go.
Taylor Darty on behalf of Aetna, Better Health of West Virginia.
Oh, thank you.
Join the meeting.
Even I don't get that kind of intro. They just push me out the door, and it's like, go do it. So Tom, you've not been on one of these before, so we really are laid back. Depending on how many people we get, I will either do or not do introductions, but we also like to have people have their cameras on because I like to see people. And then usually I also like to be able to get someone who's saying, hey, wait a minute, that guy's crazy. What he just said is just not even true. And so then we'll ask you a question or not. Man, whose house is that? That's fancy. Look at that. Is that a background or really somebody's house? You see that, Tom?
That is pretty nice. It's not my house.
Jesus.
It's too green.
I know, right? That's fancy. We could talk about them because they're not here, right? They just signed in and walked away. Look at that place. Man, oh man, the shovers. Man, that's pretty. Be nice if they had like a little dog running through the background or something. Then we could, we'd all be together. Let's see if anybody else I know I can pick on. Yeah, all kinds of people. Let's see.
Stephanie Stout
All
joined
right.
the meeting.
Hey, Stephanie, man, it's a long time, 200 years since I've talked to you. I get your emails, but I haven't talked to you in a while. All right. Well, we're about, hey there, Sean Bland.
Hi.
Hey, Sean, that's Tom. Tom, that's Sean.
Hi, Tom.
Nice to meet you. Nice to meet you.
Nice to meet you.
So you guys are kind of part of this party. And Sean, like, it did the good thing, did no slides. So we're going to talk about the COVID.
Mhm.
We're going to talk about, you hear what I said, the COVID. Sean, I just explained to Tom what the term chop it up meant, that we're going to be here to chop it up. And so he's getting hip. He's drinking water because he's like, oh man, what has Tony dragged me into this time?
Excited for it.
All right, but it is now officially 1 o'clock, but we're gonna maybe wait 2 or 3 more minutes, let people click in, because if they're like me, their notification just went off on their phone and they're
Joined the meeting.
somewhere trying to get to a computer, or either to their phone to log in. But as I was saying to Tom earlier, we had, I think, 120 people who actually registered for today's call. And I want to first thank you all for taking time out of what I know has become a regular scheduled Zoom life to do a couple of hours or an hour with us, or however long you choose to stay with us for the 2 hours. We've done something today which we don't normally do. Normally we just use this time and space for our West Virginia Stakeholders Coalition call, but we also wanted to roll out a call for the Rural Health Service Providers Network, and have that do that jointly with the West Virginia Stakeholders Coalition call. In part because we kind of knew that we didn't know how good our timing would be with the COVID vaccine rolling out and distribution, but we knew that we definitely wanted to talk to Tom Morris, who's here from the HRSA office. That's the Health Resources Services Administration Office on Rural Health Policy. We've got Sean Bland here from the O'Neill Institute at Georgetown University. Is it the School of Law or just Georgetown? Just Georgetown?
Well, just Georgetown, but we're specifically at the Law Center.
Okay, you are at the Law Center. I knew I had that in my head somewhere. We've got Daphne here to talk to us about 340B. We're particularly going to talk about 340B as something more than HIV, but for how can substance use disorder providers and maybe viral hepatitis providers or other harm reduction groups use 340B as a way to support their programs. We have got Michelle Perdue here out of Charleston to talk to us a bit about harm reduction and the fascinating and phenomenal job that they're doing down in Kanawha, Putnam, all the way down there in the south. So without further ado, I'm going to go ahead and get this party started. Those of you that have been with us before know that this is relaxed. This is not uptight. We are going to start off. Marcus, you want to go to the first slide? And here is what I wanted to do is, Marcus, do you want to talk about this? I'll introduce Marcus Hopkins, who's our state policy coordinator. So I'll let him talk to you about kind of what's going to happen with COVID in the state of West Virginia. I think most people are probably pretty concerned about that.
Thank you very much, Tony. Again, as Tony said, my name is Marcus Hopkins. I'm the policy director for the Community Education Group, and I currently live in Morgantown, West Virginia. So what you see right here on the page is West Virginia's COVID-19 vaccination plan. The first vaccination doses of the Pfizer vaccine began arriving today, and they're going to 5 hospitals around the state: Ruby Memorial in Morgantown, CAMC in Charleston, one in Huntington, West Virginia, one in Martinsburg, and one in Ronceverte in Greenbrier County. Now, Ruby Memorial and Charleston are going to serve as the main distribution points. They receive the most vaccines, and this will just be the first of 3 shipments. So what you can see on the map on the right is the pins in yellow are actually the locations where the vaccine will be delivered. And then the pins in blue, what we noticed here is that the senior living facilities that exist throughout the state aren't really very well covered. If we're talking about distributing this vaccine throughout our senior population in West Virginia, and they're in part of phase 1, then we have a good swath of the southwestern, central, and northern parts of the state that just simply aren't going to be able to access those vaccines without serious transportation issues. On the left-hand side, you will see that we have links to both the federal and West Virginia's current distribution plan, and phase 1 runs through December through February, and that's essential personnel, including senior people in our senior facilities. And then phase 2 is the general public. That starts in March. And we do have an order placed for the Moderna vaccine, which is still awaiting FDA approval. So I'll turn it back over to Tony.
Thanks. And if anybody wants this, Marcus, where do they find it?
So as soon as this meeting is over, I'm going to go ahead and distribute this to everybody who has registered for the meeting.
Okay. And so I've got Cynthia here. She says, I sit on the Joint Interagency Task Force for Vaccine Distribution. I can update you on that. So Cynthia, do you want to tell us something about that? Go ahead. That's this. So see, Tom, this is how we chop it up. The people give us the information. See, okay.
Hi, everyone. I'm Cynthia Pursley. I'm the Senior Director of Health Sciences at the West Virginia Higher Education Policy Commission. This is my first meeting with you. So thank you for doing this. I sit on the Joint Interagency Task Force for vaccine distribution with the West Virginia National Guard and many other governmental agencies. The plan for covering those other parts of the state that don't look like they're covered with these 5 hubs in this initial round is that the West Virginia National Guard will be delivering those out to the sites that are where they are needed. And so they have covered the entire state by region. They have groups of West Virginia National Guard active duty people who will be deploying the vaccines out to every region in the state. So I think we're covered in terms of that. For the senior, for people who are in nursing homes, the West Virginia and assisted living, the West Virginia Healthcare Association has been working very closely, and every one of those across the state are covered, and they will be receiving vaccine this week and next week. There was one other thing I wanted to tell you about that. They're working with the CVS and Walgreens pharmacy. That is the federal partnership with CVS and Walgreens. And so pharmacy personnel from their communities will be going out, will be receiving the vaccine from the hubs, and will be going out and doing the vaccines at the actual nursing homes and assisted living facilities. So that's just a little update. Hopefully, will calm some fears.
I think so, right? I mean, I think thank you so much, Cynthia. Thank you very much. And thank you, Luann. Luann put some information in the chat box also about where you can access information as well as vaccine. And as I say, that's what this call is all about. Who's got the information, and we all share it with each other. It's not, we don't get on here and beat people up. We get on here and share information. And if we can figure out ways to help, we help one another. So again, thank you very, very much, Cynthia. How do people access more information either through your office's website or through the state hub about, particularly around who's being prioritized when and where?
So the Joint Interagency Task Force has communication that is coming out. I just saw the most recent one that just came out. And so it will be getting out to people around the state in terms of how the prioritization is working. I did want to say one other thing about these 5 hubs. The 5 hubs are really just for this phase 1, which is to get to nursing homes and nursing home staff and critical hospital employees, those who are at highest risk in hospitals as employees. And later on, there will be more hubs that will be set up. So there will be even further dispersion of the hubs and the delivery of vaccines.
Perfect. And again, thank you very much. And if you don't mind, when we send out the slides at the end, maybe we'll send a link to the interagency site or something if there's more information there, or if you want to put in the chat where we should route people, that would be great. Cindy, I appreciate it.
Yeah, I don't have that information right now, but as soon as I do, I can send it out so that we can get it out.
Perfect. Thank you very, very, very much. All right. Anybody have anything else on that one? All right. Okay. So like I said before, I've got some phenomenal people here today, and Sean's looking at me like, he's looking at this whole thing like, is this meeting really going to go this way the whole time? Absolutely, Sean. That's what kind of party this is. This isn't one of those sit around the table at the O'Neill Institute and we can't even give people a sandwich. So I got to entertain them, right? I got to make them care about rural public health. And here we go, right? So, I have a couple of people here. Like I said, Tom Morris. Tom is the Associate Administrator, the Office of Rural Health Policy at HRSA, the Health Resources and Services Administration. Sean Bland is a senior associate at the O'Neill Institute. And a lot of y'all probably don't even know what that is, but he's going to tell you what that is. And I've got Daphne, and she's the Chief Public Policy and Administrative Officer for Equitas, but she's going to talk to us about 340B. And I've got my old friend, Michelle Perdue, who's down at Cabell-Huntington Health Department, is going to talk to us about harm reduction. And we're going to roll in COVID into this. And we're going to roll into funding for rural health policy work into this. And we're going to talk about a whole bunch of things. But the first thing we're going to do is start with my friend. He doesn't know he's my friend, but he is, Tom Morris. Tom.
Great. I thought we were friends, sure. All right, I think Marcus is going to advance the slides for me. So thank you, Marcus, for doing that. So Tony, I know you want this to be a conversation, so I'll just wait for you to sort of cue me, but I'll start with a couple of slides. I'll run through pretty quickly just to set a context, and then we'll see what questions either you or other folks might have. But I appreciate the opportunity to be with you guys today. So thank you for the invitation, the Community Health Education Group and the Rural Health Service Providers Network. And appreciate your interest in rural health. So our office is we're located in the Health Resources and Services Administration, but we have a broader department-wide charge at HHS to coordinate and sort of be a focal point for rural health within the broader bureaucracy that is HHS. So we have a couple of different divisions, and the common link in all of these is that we provide funding, I guess, to states and communities to expand capacity and to do what we can to support research and policy development focused on rural health issues. So for the purposes of our discussion today, I think that I'll probably want to spend most of our time talking about some of the grant opportunities that are available through our community-based division and through our rural community opioids response program.
Kathy Tobin, join the meeting.
And some of the opportunities that might be there also. I think go ahead.
So Tom, I'm sorry to jump in on you
ahead.
so early, but I think we do want to talk about the funding, but I think I really want people to understand some of these buckets that you do, because I would argue that I don't know if a whole bunch of people know that your office is A, there, and then B, what these different divisions do. Sure. And how they might impact their lives or impact their work or be of value to them.
Okay. Well, I'll start with the reason we're created, which is our policy work. As you all know in West Virginia, but really it's across the country, rural tends to be the land of unintended consequences when it comes to public policy. And so that was the reason our office was created just over 30 years ago, was the fact that there was nobody looking out for rural communities within our larger department. So, it's just a real challenge for rural communities. So our policy role is really the reason we exist. And it's our job to sort of look through all the HHS regulations and to at least, give people the idea of how these things affect rural communities. To do that, we fund a fair amount of rural health services research, all of which we make available through the Rural Research Gateway, and I'll show you a slide for that later. But you can't really argue policy issues if you can't back it up with research and data. And so that bucket you see for policy research, that's what that's all about. Now, along the way, we've picked up a variety of grant programs. I think the first one that came along was the research program, where we fund about 8 rural health research centers around the country. But then the next program was the State Offices of Rural Health. And so Stephanie is the director of the State Office of Rural Health in West Virginia, is a great partner for us. But really, all of the State Offices of Rural Health ostensibly try to do at the state level what we try to do at the federal level, which is to just make sure that rural is part of the conversation. And so we also run a number of grant programs through those State Offices of Rural Health to focus on rural hospitals and the fact that they're financially vulnerable, that they struggle with administrative burden. And so within each of the states, we work on quality improvement, performance improvement, and EMS integration with small rural hospitals. Moving over to the community-based division, this is an interesting set of programs in the sense that we probably have the only non-categorical grant authority in HHS. And what I mean by that is that we basically fund communities for what they say their need is, as opposed to make them shape-shift themselves into what we're asking for. So within that, probably about $70 million a year goes out to rural communities. And basically, these are pilot programs. They all fall under the broad category of rural health outreach, but there's outreach services, there's network development, there's quality improvement, and there's network planning. And with the exception of quality improvement, all the rest of those mean that, whatever the community decides is the most appropriate use is what we fund. And then we fund the grants. Most of them are funded for up to 4 years, but the planning grants we would make available each year. So in a lot of ways, some of our most innovative, creative work, I think, goes on because we get out of the way and let communities come up with their own solutions to their own challenges. Out of that philosophy came our rural community opioids response program, which we really modeled very closely on the rural health outreach programs, with the sense being that it's just more targeted on the opioid crisis. But we basically, let the communities determine what the focus will be. And in both of these divisions, the idea is we're going to fund you for a set number of years. And the thing we ask you to do is to keep the program going after federal funding. And so we're on our, I think, getting ready to start our 4th year of opioid funding. And it's at a much higher level than our other community-based funding. But given the consequences of this crisis, and you've certainly seen it in West Virginia, you can understand the urgency with that particular issue. And then the telehealth office is the one box I haven't talked about. And, as you've seen from the pandemic, one of the silver linings has been the rapid expansion of telehealth, because we finally got some of the regulatory barriers out of the way, and because people had no choice but to use it to get access to services. And in the course of that, we've probably advanced 8 or 9 years, and given the pace that we were at in the prior 10 years in terms of the expansion of the use of this technology. And so we administer a range of programs to provide technical assistance and direct community funding for folks to either expand what they're doing in telehealth or get started in telehealth. And we also fund a fair bit of research around telehealth, because ultimately, the value of this is not that you can turn on the technology and link like we're doing right now, but does it actually drive a better clinical outcome? And that's the question that's still largely out there, because the evidence base is still pretty thin for telehealth relative to other things. Although I think after this year, we're going to have much more data than we've ever had before. So hopefully we can really get a better sense of things. But the one thing I would leave you with on that, Tony, is that I think it's important that people see telehealth not as a tool only. It's not plug and play. It's one of those things that can help improve care. But if we don't have any infrastructure in the rural communities to start with, or underserved urban areas, to tell you the truth, also, the best technology in the world is not going to paper over that. So that's basically the divisional setup in a nutshell. So if we go to the next slide.
So,
Yeah.
Sean's going to talk a little bit about telehealth when he goes in after you. And I want to make sure that we're weaving in broadband and telecommunications throughout this whole conversation, in part because I think it is my personal belief, and it's my call, so I get to articulate my personal beliefs. But that one of the challenges that we're going to have going forward, even with the vaccine rollout, is how do we get access? It's going to be an access kind of question. So if it's a setting up a vaccine or COVID stations for folks to come in, how do we communicate with them if we don't have broadband? How do we, even down to transportation, how do we get them physically to the site in some instances? So I'll stop there and let you go on, because now we're at the money, and I know that's what people really care about.
Well, to your point, the underlying challenge in all those issues you just raised is numbers. Rural never has enough numbers to be first, second, or third in line. And numbers underlie all the challenges, whether they're financial or broadband related. It's just, it cuts through just about every issue we could talk about today. But let's get to the money. So basically the programs you see on this slide, the Rural Health Services Outreach, the network development, and the network development planning, those are the non-categorical programs I mentioned. Basically, we'll put out a solicitation.
What is so you're talking about?
Yeah, sure. Yeah.
Now, what is a non-categorical versus a categorical? How do these people go get this money?
All right. Thank you for busting me out of Fed speak. So non-categorical means if you look at most of the federal government, it's like reading the alphabet. A is for asthma, D is for diabetes. You get to your disease, you try to find the funding, you do it. Our authority doesn't tell you what to focus on. It only says improve access to care and improve coordination of care. You can drive anything through that, right? So that's why I say non-categorical, because we're not forcing you to fit into a category. We're asking you, what are your biggest needs in your community? And then give us a plausible plan, score well on your grant, and you get the funding. So the outreach services, the network development, and the network planning, the concept in all of those is we also ask people to come together as a triad at least. In other words, we want 3 separately owned entities to come in and apply, to come together to make that application. There has to be a lead entity. we've had a change in our statute, and now urban entities can apply on behalf of rural. And I know the definition of rural doesn't work out that well in West Virginia because of some interesting commuting patterns and just the geography of the state. But that does provide a little bit more flexibility for applicants, because sometimes the rural communities themselves are somewhat under-resourced in terms of being able to put together a credible grant application. Not that they don't have good ideas or strategies, it's just it's somebody else has to pick on another job and be the grant writer in addition to everything else they're doing. So with all of that, the idea is to have those three entities come together, and it can be more than that. And then basically, we'll fund you for the 4 years with the expectation that you would keep the grant going after that. For the planning grant, it's a 1-year grant. So in that way, if your idea is not fully formed yet, the planning grant might be the best thing to come in for and start thinking, bringing stakeholders together, thinking about what the needs are in your community and how best to meet them. If you're further along on that, then the outreach services make sense. The network program is more about getting partners to work together to build a better system of care. And so we require in that grant program for the providers to have worked together before, so that they show a history of being in a network, so to speak. So then the other grant program here that I didn't mention, quality improvement, that's very much what it sounds like. How do we drive better improvement in some of the chronic disease areas? And so that's a little bit more straightforward. And then the Delta states is mixed in there, but that's for the states that line the Mississippi, so it won't be as applicable to some of the folks on the call. Now, the opioid program I mentioned, looks just like the outreach, except a lot more money. Whereas with the outreach programs, you get about $350,000 a year for 4 years, and $100,000 for the planning. With our opioid money, the implementation grants are $1 million each, and then we're doing a special program this year just on psychostimulant drug response because of the problems people are having with the increased use of meth and those sort of things, as people maybe start with opioids, but then meth resurfaces and really never went away in a lot of communities. And so that one will be, I don't know the exact amount. I think it's somewhere between $500,000 and $1 million for those grants also. And that the guidance for those two will be out fairly soon, so you can get a sense of all of those. But with the first group, those ones that are in a community-based division, the sense is you sort of want to know the schedule so you can be thinking out like a year in advance to be ready to apply. And then the other point I'd make is that sometimes we will take some of that money in that community-based division and do a special sort of more targeted application. And two examples: one, we did one 2 years ago looking at the loss of maternal and obstetrics care in rural communities and how could we bring together systems of care to improve those outcomes. And that was the Rural Maternal Obstetric Management Strategies Program. That then made it into the president's budget as a proposal for an expansion of $10 million. And we really hope somebody picks that up because we think it's a good idea. And then this past year, we did our first ever rural HIV planning grants. We wanted to be part of that, the broader department and administration priority around ending the epidemic. We looked at the 7 states that were the target areas of that, and we sort of tailored it to that. And it's the first time in our office's history that we've ever had a targeted HIV competition, and we ended up funding 7 grants. But I think what we learned from that is that we really shouldn't limit it to just those 7 states. And the reality is you could come in for an HIV grant with the planning grant this year in 2021. The next time we compete the outreach program, you could come in with an HIV focused grant. And if you have a group of folks who've worked together before, the network development is still an opportunity there also. So what I think doing the single competition was a good idea to get our feet wet, but I think what we'd like to do is find out ways to get more applicants for folks who are focusing on HIV to come in for our regular competitions moving forward. And
so
then,
Tom,
yeah.
Tom, I want to jump in a bit on this this HIV grant, right? Because one of the things that for West Virginia now, so is that West Virginia isn't a phase 1 jurisdiction, but like Ohio, Indiana, Kentucky, Virginia, Maryland, DC, I think everybody around West Virginia, except for West Virginia, is a phase 1 jurisdiction. So would that matter if organizations were doing HIV work and wanted to come to you?
Yeah, not moving forward. I mean, I think we did that once. We were trying to stay within the broader structure of the end in the epidemic. And so we sort of got locked in on those 7 states. And I think you and I had conversations after we'd already made that decision. And you pointed out sort of the you know, the challenge that it had for states that still had great need, but maybe didn't have data that popped them into those first 7 states. So what I'm saying is that, you know, what we think probably the better way to go moving forward is to just make sure that we do more outreach to the folks who are involved in HIV care, and see if they can come in either for the planning grants or the outreach grants or the network development. And it won't matter what state they're from. They'll just have to write a good, credible application, come up with a good idea, and then, you know, if it scores high enough, we'll fund it.
Right. And now, Tom, I'm getting a couple of questions here. Are you, that people want the name of that grant? What was the name of it? And then also, will you, it sounds like you will be re-releasing it or reissuing that notice of funding opportunity again at some point for HIV specifically, or no?
Yeah, we haven't made a decision yet whether to do an HIV specific one again. We just did that as a one-time only to see what sort of response we get, and it wasn't great, you know. And part of that was because of the 7 states we limited ourselves to, but also in talking to our colleagues at our HIV/AIDS Bureau, you know, it was just really hard in a pandemic to put together the partnerships to come in for that sort of funding. So, you know, it doesn't mean we won't do another one in the future, but what I'd like to see is to have those folks come in through the doors that we know we have every year. So in other words, we're going to fund in 2021 another 15 planning grants, and so that means somebody could apply for an HIV focused one as part of that broader competition. And then what I would say is that if we don't really see them coming in that way, or if perhaps we do need to do a special competition again down the line, we're certainly open to that. But I think there'd be more opportunity if we could just make that community more aware of these grants and that they could come in for them.
All right. Thanks, Tom. Appreciate it.
All right.
Right.
But does that cover all the questions over there? Or?
Yeah, I think
Okay.
so. I think, yeah.
All right. All right. So really, this just what I wanted to touch on here was a notion that we have in our office, which is, you know, that all those grants I just talked about are about working at the community level. And, you know, we know about the daunting statistics, you know, you look at the CDC data, whether it's the, you know, the higher rural rates of the 5 leading causes of avoidable or excess death. We know about chronic disease burden. And those things can be really daunting to sort of try to change at the national level. And yet we know from our funding that at the community level, we've had grants here and there that really started to reverse that data at their own community level. And what we've sort of realized is we haven't done a good enough job lifting up the folks who really do this and do it well. They don't have time to go to conferences and present on their things or get into the research. And so what we've got going right now with the National Rural Health Association is an effort to really lift up the voice of rural community health. Because I think that's where the rubber really meets the road in terms of making an impact. And so we're not 100% sure on how best to do this, but we're really hopeful that this can be a key part of what we do moving forward, and that people will understand that even though you work at a smaller scale, you can have a dramatic impact by focusing at the community level. So next slide. And as part of that, you know, one of the initiatives we did in our rural health outreach grant competition this year, which is just getting ready to close, I think in early January, is we embedded into it a new special initiative we're calling the Healthy Rural Hometown Initiative. And what we did there was we said, if you take on one of these 5 leading causes of death, where we know that there are rural disparities, we'll give you an extra $50,000 a year. And you can do that by reducing risk factors. You can do it by doing better chronic disease management. It doesn't really matter to us. So we wanted to sort of take this from two levels. One was this micro approach, which was to basically say, we're going to fund a cohort of grantees that basically are going to show that with a targeted, focused effort, we can turn these things around at the rural community level. But then more broadly, and this all came out of the HHS Rural Action Plan and our discussions with the rest of the department, is we see this more as a conceptual bridge to bring other partners at HHS into this work. What can we do together to really focus on improving health in the hometowns and small communities across rural America? And so we see it more as a conceptual door through which they could target some of their funding too. I can't control what they do with their funding. I can only control what do I do with our funding. But I hope that we can make the case that if we work together, we can have a bigger impact. And we see some of that happening already. The National Cancer Institute is funding, as for the last 5 years, funded almost $11 million in supplements, trying to get at why we have a higher cancer mortality rate, even though we have a lower rural incidence rate. So, those sort of conundrums. And so, so this will be a key part of how we message what we're doing in the next couple of years is this notion of healthy rural hometowns. And so next slide. I mentioned telehealth before, and I look forward to hearing what Sean's going to talk about. But the fact is that there's funding out there to do telehealth, and combined together with a broader community health perspective, I think it can make a big impact. We fund telehealth networks. USDA funds telehealth equipment through the distance learning telemedicine program. There are broadband opportunities out there with USDA and the FCC. They're not necessarily easy to apply for, but they're there and they're opportunities. So, and then the other part I would mention is just that HHS now has a single point of entry website for telehealth, and what we're trying to do is drive a lot of our links to there, because just about every department in HHS is focused on telehealth in one way, shape, or form, and yet it can be impossible to sort of find all that information. So we're trying to figure out a way to make that a little bit easier and a little bit more accessible for folks moving forward. Next slide.
So, hey, Tom, I know you're gonna give us a bunch of resources right here, but I want to kind of maybe Sean, and maybe you can jump in here too, because one of the things that I find the most daunting with telehealth is infrastructure, right? Is finding the money for the infrastructure, and also that I think many people think that putting in a telehealth system is getting a website and getting a cell phone. But if you are in a rural community, that might mean a satellite phone, and that might mean costs that far exceed what some of your other counterparts are looking at. So can you just talk a bit about kind of like where broadband resources are versus telehealth resources, and kind of how we need to start thinking about this in order to increase access to telehealth? Because that slide made it look simple. Like, go over here and apply for some money and get yourself some telehealth, or go over there and apply for some money and do some telehealth. But I think everybody on this call kind of knows it's not that simple.
So me or Sean?
Whoever's crazy enough to respond.
Well, I would agree with you. It's not easy. If it was easy, we'd all be, well linked by now. No, they really go hand in glove. The greatest telehealth equipment in the world and the most committed professionals are not going to matter if they can't get a broadband connection. And you can have a great broadband connection, but if nobody knows actually how to use it, what good is that also? And there's always been that dynamic with telehealth of the battle between hype and reality. It was always the gee whiz technology aspect of it, but then, we got bogged down in issues about reimbursement and cross-state licensure. We mentioned the broadband issue. All those are surmountable. Where I've seen the biggest challenge is operationally. How do you make it work integrated into a healthcare delivery. If you make it too difficult for a busy clinician to use it or a patient to get access to it, what good is it? I've seen telehealth done really well, and I've seen people buy equipment and watch it gather dust at the hospital or their clinic. And so it's not easy, to your point. But you know, the point I was just trying to make was that there's some help out there. You know, our telehealth resource centers, we were funded basically to make sure that there was somebody you could call to say, hey, I want to do teledermatology. How do I do it? Or if you need to tell somebody what kind of camera do I need to buy to do teledermatology, we have a telehealth resource center in Alaska that analyzes all that equipment. Doesn't mean it's easy to then take all that information to apply, but at least it gives you some objective data and information to do that with. And then, you know, the grant programs, I mean, I think if you're already doing telehealth, our grant program is a nice way to sort of go into different clinical areas. If you're just getting started, I think the USDA program probably the better bet because it's more equipment acquisition focused. And then, you know, I'll probably wait to hear what Sean says on the broadband because that's a whole different chapter, especially when you dive into the FCC and the USDA programs.
Right, and so, well, and Sean, I'm gonna let you respond to this because I know, you know, Tom and his team spent a lot of time on all of these slides, so I gotta kind of use them all, you know. But here's my other question: are we seeing telehealth really being used for teleprep, HIV, viral hep, substance use disorder, Suboxone, buprenorphine? Are we seeing it being used in those for those disease states as well, or primary care visits, cancer visits, that sort of thing?
So yeah, I'll just jump in quickly. So again, thank you. I think for me, it's always just good to have like terminology just be clear at the beginning. So obviously when we talk about telehealth, like it's a very broad kind of concept that includes, you know, kind of all electronic information, all kind of telecommunication technologies to support, again, primary care, behavioral health, specialty care. It includes HIV care, includes substance use care, mental health care as well, behavioral health. But that can be in a lot of forms, obviously, and it also can be talking about telehealth to support education. So provider education, you know, patient education, supporting public health and health administration. So that's telehealth in a broad sense. And then kind of in a more narrow sense, thinking about kind of telemedicine. So telemedicine being a category of telehealth that includes kind of really two-way real-time interactions in the context of clinical care. So ideally that'd be, you know, a patient talking to their clinician or, you know, either a medical doctor or a nurse kind of in real time. And that can be, you know, just with, you know, it can be with the smartphone, it can be with internet, or it can be, as you mentioned, with, you know, just your cell phone. You can be texting back and forth, you can have an actual call. So having the access to the technology, whatever that technology may be, is so critical. And we do need to be addressing the kind of digital divide whereby we know certain populations, folks in rural areas, low-income folks, particularly people of color, don't have the same access. And so we do need to be, I mean, a big push has to be around all this funding piece, making sure that there's funding to kind of bridge that gap, make sure people have access to the relevant technology and they know how to use it. So we do need to find creative ways to use existing money to support that, so that clinics can work with their clients to buy the phones themselves, buy data plans, like all of those things are absolutely critical. And we are seeing models whereby some of those things are happening. And we are seeing models, again, where we are actually doing telemedicine for HIV. So one of the models that we highlight in our paper, and I can send a link just to kind of the new reports that we released in October of this year, one is on telehealth specifically. We look at the Medical Advocacy and Outreach Program of Alabama, so MAO of Alabama. They've been doing telehealth for nearly a decade now, and they've, you know, specifically developed their program to service low-income folks in rural areas. One of the cool things about their program, and so again, we highlight it, we show you kind of the steps to setting up a telehealth program if that's something that you're interested in doing. You know, there's involves actually collaborating with partner sites. So they have partner sites where folks go and, you know, visit a nurse. So they're still doing some in person, but they're able to connect with their specialty provider, whoever the doctor is somewhere else, through telemedicine visits. So you're able to do telemedicine to conduct an exam. They have images and sound, so you can kind of transmit all of that information to an MAO provider who is giving real-time advice to that client. And so that's a model whereby I think one is—
What's easy, Speedy? What is an MAO provider? You just said you just did some of your in the Beltway stuff. What's a MAO provider? You might want to explain to the people.
So in case I didn't spell out what the acronym is, so Medical Advocacy and Outreach, that's the organization in Alabama, and the acronym is MAO. So that the organization, so providers that work specifically at MAO, that's who I'm talking about when I'm referring to the provider. So again, they have their system, which is called eHealth. It is a telemedicine program that uses video chat between the client and the provider at different locations. So a client goes and they visit a nearby clinic that's staffed usually by a nurse, who then uses the telemedicine equipment that they have available to them to conduct a medical exam. And they transmit all of the information from that medical exam to a provider, so a medical doctor who's at MAO, so that they can do real-time consultations with that client. And so they have so far been able to operate out of 3 different provider locations and 11 clinics serving 28 counties, all in Alabama. And so it's been I think a model they've been able to scale up again to more and more clinic sites and to reach more and more patients. And they actually have really great outcomes with it. So one, I think clients are satisfied with it, but they're also seeing in terms of their HIV kind of just retention and HIV telemedicine care, that they have comparable rates for folks who are doing kind of the telemedicine type visits and folks who are doing kind of in-person visits. And they're also seeing really good rates of viral suppression as well.
Is this something that they could replicate somewhere else? Is this something that they could give like technical assistance to others on? Is this something you could give TA on? Is this something Tom could give TA on if an organization wants to expand to be able to do this? Because we don't want them to end up with, the printer sitting in the corner or the camera sitting in the corner, or, calling Tom going, I budgeted for the equipment and I bought it, but I just didn't use it.
Absolutely. So yeah, I'm happy to put folks in touch with folks at MAO. So again, that's the Medical Advocacy and Outreach in Alabama. Their executive director, Michael Murphy, has given lots of talks across the country, in particular a number of HIV organization conferences, International AIDS Conference this year, and a number of other places. So he or maybe one of his staff could, be in touch with folks who are part of this association to kind of go through those on the ground steps. Again, that's not what I do as a policy person. I wouldn't be able to tell you the steps of setting it up, but that definitely is possible. And again, we see a lot of value in that, which is why we highlighted particularly their program in our report, and particularly because it's focused on a rural area and like how they've done that in kind of a more rural context. But yeah, just the other thing around just like capacity and like actually reaching folks. Again, they have these provider locations and they have their clinic sites. I think there are lots of ways also to collaborate and leverage kind of existing community-based organizations that are in all of our communities to help to deliver kind of telemedicine as well. And so again, in some cases, if folks don't have their own internet access at their home, going to a nearby community-based organization could still be a way in which they can, have access to internet, be able to kind of do telemedicine from that context, but still wouldn't have to go to a particular, clinic, maybe even a clinic where, again, they could be, one, they have privacy concerns, they may worry about stigma, they may worry about any number of things, but at a community-based organization, they feel a lot more comfortable kind of going to those kind of spaces. And so figuring out the ways to have the right partnerships between our clinical providers and our community-based organizations to kind of make sure telehealth works as it can work in a particular community, I think is really important. So
right. So no, I wanted to thank you, and I actually do know that program and think very highly of it myself. Actually, it's who I called when I was thinking about crazily that we were going to do telehealth direct services. And I was like, yeah, this is what I'll do. And then I realized I don't want to do that kind of work. That's hard work. That's hard stuff, man. People that do that direct service telehealth work do a very important service, but I think that kind of making sure that there's access for clients at all levels is the kind of the acts that I see with telehealth. The other thing that I think that kind of comes up for me right now, particularly in rural communities, is seeing education as a public health concern, given that we have COVID and we have so many kids now that have to access their school or lesson plans through telehealth. And then we found out in West Virginia and other rural communities that given the high rate of families that don't either have broadband in their home or have access to broadband technology or have access to Wi-Fi or laptops, that we need to do a better job of increasing just their overall access to telehealth and telecommunication services. Tom, I'm going to let you finish your, I think you have 2 to 3, or maybe 25 more slides. I don't know how many they gave you.
Not 25. Yeah, it's just these two right here. If you're interested in some of our research, the Rural Research Gateway, we post all the studies on there, contact information for all the researchers, so good resource there. And then we're required, to run a national clearinghouse, and we do that through the University of North Dakota that does the Rural Health Information Hub. And there's a lot of great stuff on there, including our Models and Innovations Hub, where we feature some of the grantees who we think have really been noteworthy. All of the source books that have all of our past grantee cohorts are in there. So if you're curious how people have used our funding in the past, RHA Hub and the Community Health Gateway are a good way to get there. And the next slide is just, we do a weekly newsletter where we try to give you a sense of what's the most real relevant stuff that we think you need to know. And you can sign up for this by just dropping Michelle Daniels an email, and then we'll put all our grant announcements and other funding opportunities we see there. And that's really the end of my slide deck, Tony. So thank you.
But thank you, Tom. Now, Sean, I'm going to jump to you, and then actually we're going to bring in. We just bring in everybody. We're going to bring in 340B. We're going to bring in harm reduction, because I think it's all connected, right? So the question, before us is kind of multifaceted, right? It is, how do we increase access to public health in rural communities across the United States? Not just HIV, not just COVID, not just education, not just harm reduction, but how do we get people access to the care and services and treatment programs that they need? That's the problem that we've got, right? So we've got a transportation problem. We've got an opioid crisis. We've got COVID now kind of rolling through most of, I guess we just call it red America. It's like rolling through like a train that has now said, we didn't put in enough preparedness programs. Harm reduction programs. And now, we can use 340B to pay for, and most people think of 340B as a HIV or viral hepatitis, but I think we can also be thinking about 340B in the context of substance use disorder programs. I think 340B has been underutilized as a rebate in substance use disorder programs, and particularly in rural communities. So, all right, there you go. That's it. That's all I got. Now you guys talk amongst yourselves. My work here is done. Mic dropped.
Thanks for setting us up. This is the conversation that we need to be having. I know we don't want to just have approaches that are siloed, that we're just responding just to HIV or just to a particular disease. We want to be able to increase access for all. And specifically when we're doing that, we do need to take into account, we need to have intersectional approaches, and we need to have intersectional policy. So a policy not just for HIV, but we need to be addressing all those social determinants that you mentioned. And we also, while doing that, we want to have a lens that's a health equity lens as well, where we're focusing on the populations that are most impacted, particularly with a focus on, again, communities of color, particularly Black, Latinx, also Native communities, because we know a disproportionate number of Native communities are in rural areas. So we do need to have that kind of equity lens in terms of what we're doing. And so I think that's always like, I think the starting point for what we do. And again, I'm going to be orienting when I'm thinking about this, because I'm thinking from HIV, that's mostly what I do, I still think it needs to be intersectional. So when I'm thinking about HIV, first and foremost, where we are now, we're talking right now about ending the HIV epidemic. We have the Trump administration that has set out a goal to end the epidemic in the next 10 years, so by 2030, which means specifically reducing the number of new HIV transmissions by 90% in that time. How are we going to get there? And so I want to just first point out like some research that just came out, I think is really important to kind of keep in mind, because I think it really brings together all the topics that Tony and then I've also already mentioned. So a study that just came out earlier this month, which was published in the Journal of AIDS, it modeled how can we achieve the HIV epidemic by 2030 in 6 cities. So again, taking the fact, this is the cities, and then we have to then compare like, oh, how are we going to do this in the rural areas? But they looked at 6 cities, Miami, Atlanta, Baltimore, New York City, Seattle, and Los Angeles. That study found that under ideal implementation of our combination strategies, so when we think about combination strategies, we're thinking about things like treatment as prevention, so making sure that every person living with HIV is on treatment and they achieve viral suppression. We know you prevent, it's good for the person living with HIV, good for their health, but it also means they can't pass the HIV on to any sexual partners or onto drug-using partners as well. It significantly reduces the risk of transmission for in the context of drug use or injection drug use. Thinking about things like PrEP, pre-exposure prophylaxis, also post-exposure prophylaxis, and syringe services. So even if we, under ideal circumstances, we get 90% coverage, that's what was in the study, population coverage for all of those interventions, we still would not end the epidemic in all of those cities. So only 4 out of those 6 cities would end the epidemic. And so again, these are cities that have, in many cases, so again, we're talking about New York City, we're talking about Seattle, cities that have political support behind HIV and the populations that are impacted by HIV, that have funding, that have infrastructure, which doesn't exist all over the country and definitely not in many rural areas. And so even there are challenges to ending the epidemic. Right. And even further, I'm sorry, Tony, yeah?
No, I'm getting ready to interrupt you, and I'm gonna go to Daphne. She's gonna be like, what a strange pivot. What does 340B have to do with this? But I think 340B has everything to do with it, because I think 340B has everything to do with access in rural communities and kind of what some of the structures are out there to have an infrastructure in place that I don't think rural organizations use. So Daphne, I know you had 17 million, 55 billion trillion slides, and we're not gonna use those. Marcus, you're gonna put up the what is 340B slide, and Daphne's gonna talk about that, but we're not doing that 755 million slide. I'm trying to tell you, she had more slides than Tom.
I'm guilty as charged. I like words and they make me feel comfortable. So sometimes I add a lot of them. Yeah, I mean, I think, and actually we can even probably do one better. So after this slide, Marcus, if you want to go to the slide, that's the image of, I think it might be the next one or one before it, I can't remember. That's just the image of how the 340B program works. That's it. This is probably the most important one. And, forgive me if I'm telling you all things that you don't know.
Daphne, before you launch into this, I don't know if Marcus, can you take this down for 1 second? I just want to see by a show of hands or a thumbs up, how many people with a thumbs up even knew what 340B was before we started this call? All right, a lot of people aren't on screen, but it seems, I think nobody knows what this is in this context. So That's why I think you're so important for us today.
So the 340B program is a program that certain safety net providers can participate in. And I do have a slide on that. I can give you a high level, the ones that you care about. So federally qualified health centers, Title 10 family planning clinics, rural critical access hospitals, many of which are rural hospitals, disproportionate share hospitals. So, you know, hospitals that see a lot of underinsured or uninsured people, have a high volume of uncompensated care, Black lung clinics, hemophilia clinics. Those, it's a discrete list, a fairly small list of providers that can participate in the 340B program. Oh, Ryan White clinics, of course. So those providers can participate in this federal program that's created in federal law. And basically what it says is that those safety net providers can buy drugs, outpatient drugs, at a significantly reduced rate and be reimbursed at the retail rate. And this graphic here shows you exactly
So
what
you
that
don't
means.
mean, you don't mean like crystal meth, weed, and off-brand Oxycontin when you say buy drugs. Remember the crowd we dealing with here. Now we got to get specific here.
Yeah, absolutely. It's a great reminder. So I mean, prescription drugs, over-the-counter prescription drugs, name brand and generic. All of those outpatient drugs for essentially patients of that covered entity, of that safety net provider, those outpatient drugs can be purchased at a really significantly reduced rate, but reimbursed at the retail rate. And the covered entity then takes that savings, and you can see it here on the slide, and is required to reinvest that savings in its program. So this is just a really simple example. The drug, the safety net provider buys the drug at this reduced rate of $600, is reimbursed at $1,000, and takes that $400 and reinvest it in its program. So at Equitas Health, for example, that has allowed us to add the kinds of programs that we provide: behavioral health, dental, some really intensive case management by our pharmacists. And it also really importantly allows us to make prescription drugs, outpatient prescription drugs, available to our patients at a significantly reduced rate also. So no one walks out the door of our pharmacy without the drugs that they need, even if they have a high out-of-pocket cost. So it allows us to significantly subsidize the cost of drugs. It also has allowed us to open service sites in other parts of Ohio. So Portsmouth, for example, which, if you're familiar with Ohio, is in Appalachia. Athens is pretty close, and other parts of Ohio that aren't necessarily in Appalachia, but may be in other rural parts of the state. So the trick about the trick with 340B, well, there are a couple. One is that you've got to be the right kind of provider. So not just anyone can participate in 340B. The purpose of the program is to stretch scarce federal resources. So essentially, in exchange for a federally qualified health center or a Ryan White clinic seeing anyone who walks in its door, regardless of their ability to pay, or meeting certain income requirements, being, you know, perhaps a low-income patient or someone who needs a lot of resources, the federal government says, you know, thank you, FQHC or Ryan White Clinic, for serving these underserved patients. In exchange, we'll allow you to participate in this program, and you can take this savings and reinvest it in your programs. So one thing I actually, go right ahead.
Hang on, Erica Vaughn, do you understand what she just said to you? Do you now understand 340B? Because I saw you scratch your head. Now I just want to make sure that we have got the itch scratched.
Yes, my itch is getting scratched. This is wonderful. I'm the executive director of the United Way in Greenbrier Valley, and I've been on about a month, and this is such wonderful information for me to take back to our community. I'm very grateful to be invited to this call.
All right, I just want, because I saw you scratching your head, I wanted to make sure, because you know.
I'm a head scratcher.
This 340B is a bit of a head scratcher.
It's probably not going to be the first time you'll see me scratching my head during this call.
All right. right, go ahead, Daphne. We're with you. Come on. We're going to get more patients access with 340B.
Yeah, so the first trick, like I said, is that you've got to be the right kind of provider that can participate in 340B, not just anyone can. And I'm really simplifying the requirements, but the first is that you've got to be one of those kinds of providers that I mentioned. So Ryan White Clinic, critical access hospital. And I had a slide in here. It's something like, don't quote me, but I think 62% or something like that, 62% of, oh, is this it? Yeah, 62% of critical access hospitals are those in rural areas. Now, so you've got to be one of the right kinds of providers. And if you are, you can participate in this program and take that savings and reinvest it in your programs to serve new populations, to provide new services. So substance use disorder services, absolutely. We at Equitas Health operate a syringe access program. We can't use 340B savings to purchase syringes, but we certainly can use our 340B savings to help subsidize some of the administrative costs of operating our syringe access program. Like I said, dental, behavioral health services. So you can serve new populations, you can provide new services. The point is to take those scarce federal resources and stretch them to make your dollar last longer, if you will. So one thing that I was going to, that I think is important to know is that Ryan White clinics in particular and federally qualified health centers have more restrictions on how they can use their 340B savings than hospitals. It's one of the frequent criticisms of the 340B program. But I think it probably works out as an advantage in a rural area that has a critical access hospital, because that entity, that safety net provider, can use their 340B savings more broadly than can a Ryan White clinic or a federally qualified health center. So it's, compliance with 340B is sort of a headache. It's a fairly heavily regulated program, like most healthcare programs are, but 340B itself is sort of requires a pretty hefty compliance program, but the benefit, if you will, is pretty significant. And I guess I'll also just say this while I'm talking about it, that another criticism of the 340B program that I hear a lot is that organizations that support 340B are supporting high drug costs or aren't in favor of lowering drug costs. And I would say that's not true. But I also say, look, we're sort of stuck with the drug pricing system that exists right now. And it might not be how I would design a drug pricing system, but it's what we have. And that drug pricing system really is built on, or one of the components of the drug pricing system is 340B. And so, that's how we get a significant portion of our revenue to provide services to our underserved, uninsured, and underinsured patients. So there are, and I won't go into it unless there's a significant desire, but I'm guessing there's not. There are a bunch of threats to the 340B program by drug manufacturers, insurance companies, pharmacy benefit managers, state Medicaid programs. And when we're advocating against those changes to the 340B program, we say, and this is true, that a covered entity like Equitas Health, may not be able to remain open if the 340B program goes away or is changed in significant part, because it's just how our funding is structured.
So I've got two things for you. One is, Luann, do you have a specific question right now for Daphne, or do you just want her contact information?
I'd just like to get her contact information.
Okay, we'll make sure that you get that out to everyone.
Thank you.
My big question is that a lot of the providers in our network are medically assisted treatment facilities. Smaller organizations may have multiple sites in multiple states, may actually have some in Ohio, Kentucky, and West Virginia. may not, may do some HIV work in just that they don't have a pharmacy. They don't have a pharmacy partnership. Is this their jam, or do they need to go somewhere else?
So you've got to be on this list. This is not an exhaustive list, but it's pretty exhaustive. So you've got to be on this list. So it's certainly not unheard of that an FQHC might have an MAT program, or that a hospital might have an MAT program. I suspect that probably not many other of these provider types have their own MAT program, but they might. And if you're on this list, you don't have to have your own in-house pharmacy. So you can contract with the pharmacy. Equitas Health actually acts as a contract pharmacy to other entities as well. There are other eligibility requirements that I haven't listed here that, if you're really interested, are probably worth looking at. But the bottom line is that like a freestanding community behavioral health agency itself can't qualify. You've got to be on this list. But if you're an FQHC, for example, that provides outpatient SUD or mental health services, then you might be able to qualify. I mean, you could qualify if you're an FQHC, and you don't have to have your own in-house pharmacy. But it really doesn't help, like what in Ohio we call community behavioral health agencies, just outpatient sort of freestanding SUD or mental health providers, if you will.
Right. Okay. So I'm gonna try and tie this all back up again, because I know we still have Michelle out there, and is there going to be any sort of reimbursement after COVID? I mean, will there be any reimbursement if I come to a clinic and I've got a COVID related condition? You've got black lung here, but we know that there are respiratory problems associated with COVID post-care. Is there anything that, any of the treatments that'll be on the 340B list? And then I'm going to come back to you guys, everybody, and Michelle, because I really have a question about how we're going to do a better job of getting particularly our SSPs linked into getting those folks that I think are vulnerable populations access to COVID testing. And I think a lot of that might have to come through a mobile and portable entity.
Yeah, so think of 340B as just another revenue stream, just like reimbursement for medical services would be. It's just another revenue stream. It's a little bit restricted, but if you're an FQHC or a hospital, it's not nearly as restrictive as if you're a Ryan White clinic. So it's just a revenue stream that, if you think about that graphic I had, you take that $400 from that prescription, you put it back into our organization, and that can be used to do a lot of things, including subsidizing healthcare. So, or providing telehealth services. So yes, 340B does help provide all kinds of services, medical services, access to lower cost prescription drugs. It defrays some administrative costs. So it is just a regular old revenue stream that can be used to help subsidize the cost of serving an underserved population. Uninsured, underinsured. In Ohio, we have Medicaid expansion, so we don't have a high volume of really uninsured people, but we still have a significant amount, or people, frankly, who are insured but can't afford their prescriptions because their deductible is really high. We can take that 340B savings and help defray the cost of medication so that they can walk out the door, even if they can't pay their out-of-pocket costs. So 340B is really powerful. It's a powerful tool. If you can, sort of get over the compliance headache, which organizations do, because 340B it's a powerful tool that we have, that the federal government gave us to help serve underserved people.
So, all right. So Tom, does your office do anything around the 340B, making sure that rural populations have access to it?
Our main focus is promoting it and trying to explain what's happening from a regulatory standpoint. So we work very closely with the HRSA folks who administer the program. But it's been a, you know, as was just noted, it's been a lifeline for the critical access hospitals who are eligible, and really primarily through the contract pharmacy option. That it's really made a difference for them in terms of it's significantly lowered their acquisition costs, and that's created more flexibility in their revenue. So in some cases, it may be keeping them from being in the red.
And so Sean, I then think it comes back to a couple of the big, what are your papers called? Big ideas, or what are they called? Big idea papers?
Yeah.
Huh?
Big ideas.
Yeah. So because you've done one on substance use disorder, you've done big ideas on telehealth and telemedicine. I believe that you've done one, you guys are getting ready to do one on West Virginia or rural America specifically. So help me understand how all of these things are related to being able, because listen, I come back to access. How do we get people access to the services, to the tools, to the programs, to the money, to the people, to the policy, right? Michelle, are you on here somewhere? Perdue?
Michelle Perdue.
Yeah, you're here. This is one of my favorite people on the face of the planet. But she knows that. And but Amy Snodgrass is on here too, and she has my favorite name. So you don't win favorite name, but
I do.
but so Michelle, you are at the health department, right?
Yes, Cabell-Huntington Health Department.
And so you guys are one of the spots that's getting ready to roll out COVID.
Yes.
You got a harm reduction problem. You got a harm reduction challenge. You provide harm reduction services. You now started providing remote telehealth services. So, Michelle, help us understand at the front lines, grassroots, health department level, what's happening down in Huntington and Cabell.
Well, we've had to change access to harm reduction. We never changed our hours, and we've never closed our program, luckily enough. But obviously COVID-19 has had an impact on our services. I've been quarantined twice, and luckily I never had the virus, but I still had to be quarantined because of exposure. There's 4 of us total staff, and for 2 weeks, 3 out of the 4 were quarantined. So that left 1 person trying to operate the entire program. Of course, they could reach me remotely, but then they had to serve all of our participants. And people were allowed to come every single day of the week. And now because of the coronavirus, we have limited to that to twice a week for them to come. Now, we do have a population of people living with HIV, and we do have a Ryan White program representative at our health department. So anytime that someone ends up testing positive, one of the first things they will do is meet with Stephanie, that representative. So we're lucky enough to have that. We have community health workers from Marshall Health that are also recovery coaches, but they've struggled getting people into a treatment program since the coronavirus. But they will work with all of our participants, but the specific thing that they're supposed to work on is people living with HIV and hepatitis C. making sure they're connected to any services that they need. Unfortunately, coronavirus has had a big impact on us. We're testing every single day, and our participants are more than welcome to get a test. It doesn't cost anything. It's obviously free. But to give you an example, sometimes, I mean, they're testing 100 people in a day or over 100 people.
You mean when you say testing, because now remember
I'm talking about testing the coronavirus.
Okay, right. So now when you, for every corona test, for COVID-19 test, are you also testing either for HIV or for hepatitis at the same time?
Well, that's had to slow down as well. Obviously, if a new patient comes in, we want to get them tested for minimal HIV. We're starting to see a rise in our numbers again. And I think it's probably because people, I'm speculating, but people may think we have closed, even though we haven't. Some people are scared to get tested. So, but we're still testing for HIV, but the other, like any STIs, hepatitis, that kind of fell off because we're down 5 nurses. We've lost 5 nurses due to retiring, health issues, things like that. Right now, we only have 2 nurses to cover the health department. So they've had to hire on temporary people just to cover for COVID. So this has hit us, made a huge impact. That vaccine can't come quick enough. I don't know how people feel about the vaccine, but for us, it can't come quick enough to try to get back to more adequate services for our participants. I mean, we're doing everything that we possibly can not to leave anyone behind. I've even have a grant to get snacks and water, clothing, things like that for our participants. But we're still trying to test as much as possible. Prior to COVID, we were testing every 3 months for HIV alone, and then at least every 6 months, all of any other infectious disease. But that has hit us a great impact because I don't have nurses to do the testing for our population. Now we will see on a new person coming in, we will try to get them tested for everything. Now, if someone comes in and says, I want a specific test, that will be arranged. I mean, that's never going to be denied. They just may have to wait a little while for a nurse to be able to serve them.
Right. So Daphne, am I understanding this correctly that health departments cannot apply for 340, cannot have a 340B infrastructure? Is that right?
They actually can. There's a mechanism for local health departments to apply to become an to apply to participate in 340B if they participate as an FQHC. There aren't that many, and I'm not terribly familiar with the structure, but there is a mechanism by which a local health department can be an FQHC, and in that capacity, they could participate in 340B. But outside of that, no.
Right. So I think thank you. So I think that, Michelle, you bring up absolutely what, again, I keep coming back to, I think is my primary set of considerations right now, is how do we deconstruct the silos which exist between these disease states, and how do we increase access? So because one of the things that I wonder about is that, yes, we may have vaccine available, but what sort of vaccine preparedness are we doing? What sort of vaccine preparedness are we particularly doing in rural communities, to talk about what a vaccine is and what a vaccine isn't? How do we do that? How do we find more tools for education and more opportunities for education. And I think, Sean, kind of coming back to your piece about the use of broadband and telehealth and telemedicine. I mean, you know, I think people can kind of forget that this is a 2-dose regimen. So there has got to be some engagement in that 30-day window between that second dose. And do we have a plan? All right. Hey, Dr. Reedy, do we have a plan to actually educate the community and to be able to do patient follow? I mean, one of the things we saw in COVID screening is that, you know, kind of our contact tracing went off the rails. And if we need to now in these rural communities keep a handle on individual patients to make sure that they come back for that second dose, which we know is critical, how does that all fit into all of this? I know this isn't what you signed up for, Sean, but you're here now.
Yeah, no, this is a great conversation. I think I just want to, I guess, go a little bit back to kind of 340B and telehealth a little bit, or just about being creative to find, well, we need to advocate for, but being creative and finding funding to support, again, addressing these gaps in broadband access and other gaps that might exist. I think there's a lot of opportunity even to look at kind of the existing kind of COVID relief funding that has gone out and that still hasn't, you know, all been spent in some cases, to make sure that that money is being used appropriately to support broadband access, for instance, and to create, you know, to support remote learning and training for all of the, you know, all the telehealth services that need to get out there. And I think there's also a role for figuring out, you know, if we can use and leverage kind of the Ryan White program to kind of think about what are the synergies between Ryan White and kind of the existing COVID relief and any future COVID relief that kind of goes out, to make sure, again, that we're funding the types of services in a way that, again, these services aren't just used for HIV, they're going to be used for, you know, all of the disease states that you mentioned. And so I think that's a critical part of the discussion. So we need to continue to, again, advocate for the next wave of relief packages and make sure that that money is there and that there's flexibility to use it, and make sure that it's going to address the concerns that you've already raised.
All right, but so, and this is, again, everybody, this is a conversation. If you have questions, put them in the chat. If you want to just shout out your question, like I'm doing so rudely, feel free to do that as well. But that, I mean, that was kind of like even how I think Tom and I really met, is because I contacted Tom and said, hey, you know, this thing called the Provider Relief Fund doesn't really give money or support to organizations that don't have a CMS number, that aren't providing this higher level of medical service. If you have a CMS number, you can get money out of the Provider Relief Fund. But if you're providing frontline harm reduction services or SSP, or you need a mobile unit because you can't be in your office, or you need to buy those satellite phones or put in place a telehealth program, that's kind of where I think we also have to figure out how to get money into the new package for those type of services, not just the primary medical services. How do we make sure that a Dr. Reedy over in Berkeley, Morgan, Jefferson, I think you're running the trifecta over there, aren't you, Dr. Reedy? How do we make sure that we are getting him underlying support that he may need at a health department for, whether it's PPE or whether it is additional personnel? I think you heard Michelle talk about they've lost 3 nurses. How do we get the people what they need? Not just, you know, I mean, because I think that's the other piece of this, is that small county and rural health departments are the key to our healthcare infrastructure, and it's crumbling. It's crumbling. And we've got to be able to do something about it as I think in partnership with them. And so I think I'm like, how do we do it? I mean, I don't know how Dr. Reedy's not pulled all his hair out, but how do we, I don't, how do we do it? How do we do it, Tom? Tom, yeah, Morris, you're the government.
Yeah, no, I would, yeah, I knew the government question was going to come up eventually. I wish there was an easy way. I mean, there's not. I think your point about local public health is an essential one. And my eternal hope is that coming out of this pandemic, that there might be some attention to the fact that there's a need to rebuild it. Or doing that against my normal cynical impulses, but I really do hope that happens. Even the grant funding I mentioned is temporary. It gets things started, but it doesn't provide the sustainable revenue source that I think is essential to keep a lot of these services going. I guess the only thing I could offer is that our funding can be part of that solution. It can at least be a way to try things out. But the more important thing I think is just having funded those sort of communities for 25 years now. I am always amazed at how effective people are at connecting various streams of financing to cobble together the services. They shouldn't have to do it. It shouldn't be this hard, and yet that's really the key is enabling those sort of dot connectors at the community level to tap into it. And how do we lift them up? Unfortunately, there's hardly any funding for the sort of leadership development that we need to create these doers at the local level. And I've come across them only because they come in for our funding, but that they give me hope.
Right. So Michelle, what is it that you need? What is it that you see? How can we get more access? And Dr. Reedy, you're the one that dialed in, so I'm gonna probably come to you with the same question, because I know that you guys have been hit upside the head with COVID, but you still got an HIV problem, you still got an opioid problem, and a Hep C problem, and some more problems, and a veterans problem. Michelle, that was a whole lot, I know.
Yeah, it was. I was trying to take all of that in for a second. So what is your question for harm reduction?
Yeah, what do you need? What are the access points? How does telehealth or could telehealth play a role in that? I mean, what do we need to do?
I'm not sure, honestly, to say it, to have an answer of what we need to do, because I wish we could provide more direct service to our participants. Telehealth, I don't know if it would work with our participants. I mean, not all of them have access to like a phone or stuff. I mean, we are participating in a survey right now, and not all of them have phones, and it required a phone call. And so we've allowed them to go into a side office to use the phone to participate in the survey about how COVID has impacted someone, a person who uses drugs. But it's follow-up is hard. I mean, we're a small staff. We do have the community health workers, and I can't explain or express, and I'm sure everyone is in the same boat, how much the coronavirus has affected our ability to provide service. Because, we were giving, and we still do, we give out medications to our participants. We worked it out with Marshall Pharmacy, so that a lot of the patients that take HIV medications, they get them directly here. That's not, I mean, like I said, we're short-staffed, and you're trying to find someone who can hand out those meds, right? Because we're not allowed to. Like, I would know exactly what to do. It's not hard. You just need a little bit of training of tracking everything and writing it all down. But we're not allowed to do that. So then I've got to stop and try to find a nurse that can hand it out. So, it's almost like we need our own mini little health department of harm reduction services, and have clerks and people, nurses dedicated to being able to talk about safer injection practices and their risk for contracting an infectious disease, and getting them connected directly to the Ryan White program, because Ryan White here, without them being here, it would be really difficult. They help us a great deal in connecting our HIV population with services that they need desperately. Our community health workers do that too, but they're trading off every other day because we're limited to how many people can be in our area. Well, I say area, like our where we give our services. We can only have 5 people at a time, and that includes staff.
Right.
So,
Right.
we need a lot. And then when you were talking about money earlier, I was getting ready. I'm very concerned with the supply of Narcan that we have. It's expensive. And I think I have 120 units left. I don't have any money to get Narcan. And I was applying for a grant specifically, and I didn't see the fine print that said, you can't use this to buy Narcan. Specifically, it was in there. And I thought, oh my gosh, here I am working on this grant, and the whole thing, I missed that one line. And I thought, I have spent a month working on it. And then I thought, oh my gosh, I can't even buy Narcan with it. That's a restriction. Like someone mentioned earlier, you can't buy syringes. Without the Hep Connect grant, I wouldn't be able to provide syringes because it'd have to come out of the health department's pocket. And right now, we're all hurting. I mean, we're blessed in Cabell County, but at the same time, it doesn't mean it's just flush. I mean, we don't have money just to spend. So.
Right. So let me, Dr. Reedy, I want to ask you, because I know that, because I've talked to Angie a couple of times, and I know you guys are really like I said, you just opened up another harm reduction site in Morgan County, but you've got Berkeley, you got Morgan, you got COVID. You got everything there. Can you talk a little bit about kind of what you've seen and what you need?
Well, that's so much that you need. The fragmentation of care, of course, is a major problem. If we would talk about telemedicine, the Jefferson County Day Report Center has really embraced telemedicine, that they have a psychiatry group that works with them, and they, even before COVID, they were very much involved in that. So their practitioners did not physically need to come to them, which when that happens, you don't have a medical shortage area, that you have those people wherever. And when I was years ago at the Shenandoah Community Health Center, we were a subcontractor on the Ryan White, and we had some internists and family practitioners, nurse practitioners, who were very interested in taking care of people with HIV, but didn't know all the latest of everything. But mostly what they need is primary care, and being able to connect with an interested practitioner at WVU and nurses as part of that program. He would meet with us by regular telephone conference once a month, and available in between, and we go over cases with numbers instead of names, since it was somewhat of an open mic, and we'd go through things and he'd give us advice. But the technical advice that he gave us was relatively small. It was crucial, because if you don't give them the right medicine, it's no good. But he just needed to supply that, and of course he gave us a lot of other backing because he was an excellent physician. But most of their care was not something that needed to be at the university. And so finding specialists who support that they only have a small piece, and that's whether it's cardiology or anything else, is unique. But I think that's what's needed. Unfortunately, our health department, we've got very poor connections with the internet. Doesn't support as fast a traffic as we'd want all the time. And then for many of the patients, there just isn't even any. My head nurse lives on the other side of the mountain in Berkeley Springs, and I can't reach her on the weekend unless I call her landline, because her cell phone supplier and mine don't talk, or something. I don't know what it is, but so, and for the state, of course, that's a big issue, and I'm not sure how that's going to change with landlines. But there's a lot of opportunity. There's certainly many things we bring people in that they don't really need to come in. I did early in the COVID when I was doing oncology. I had the opportunity to do a lot of telemedicine visits, and you can get great information. If you think about your average stable HIV patient, you don't really need to do a physical exam other than look at them. You do not have to have them come in, and transportation is one of our great problems. With harm reduction, it's a great problem, but immunizations and things like that. We've talked about when we don't want everyone in the building, how to just talk to them on the phone, really do the visit before they come. All they need physically to be here is to sign the permission slip, which of course with the right technology, they could do that by the internet. They can come in, we can give them the shot in the car. They don't need to come in. They don't need to waste their time sitting for an hour in our waiting room. So there are a lot of things we could do better by changing our habits, but that's hard to do. But COVID has certainly made us change a lot of habits.
Right. So are you, I want to ask you two things. One is that what do you think we need to be doing, not just in West Virginia, but I think across rural communities to prepare folks for a vaccine and to prepare them for follow-up in light of COVID?
Of course, that's a question we're trying to first, I have to figure out what's the process. It's come down real quick in the last week, and there are all these calls, but the calls tend to, and I haven't been able to be on most of them, of course, but they tend to focus on some little process issues and not necessarily consistently give the overall picture. It's not a criticism of those doing it, but it takes time to learn, because we all come to it with different levels of understanding and knowledge of the process. But just as I signed on here, I read an email from some home health agency that wants to know how are they going to get their shots in 1C, and it's like, well, you called the right place, but I'll have to find the answer for you because I don't know.
Right.
So learning how to do this networking and figuring out our community partners, this is a real challenge, because we're going to be thrust way up front, it's going to require far more resources than we have.
Right. And I think I'm asking because I want you to know however we can help. If it's post something to say, don't come over here for a vaccine today, but come over here for a vaccine on Tuesday. Whatever it is, however we can support you, however down in Cabell, however we can be of a support. We want to make sure we support you, because we also know that you are right now understaffed, underfunded to get this done, but we are in the middle of a public health emergency. So, anything we can do, please know that.
Fortunately, the vaccines for the general population, unfortunately, but from the standpoint of implementing it, they won't be available for a while yet. So we at least get to work with some of our usual partners like hospital, nursing home, and EMS, police for the first few weeks, but then it's going to start expanding very quickly. And the phone lines, getting the word out, don't call the health department asking when you can sign up, because you can't tie up the phone lines for that.
Right. Okay. Well, we can definitely do that. Hey, so I'm gonna pivot for 1 second. Hey, Stephanie Lancaster, do you have any doses of naloxone that you can help Michelle Perdue down in Cabell County get?
I don't have any in my personal stash because we don't carry them that way, but I'd love to connect with Michelle and understand, number one, what the grant funding was that precluded her from applying, and also if there are other grants available that maybe she isn't accessing right now.
Right. Michelle, do you know Stephanie?
No.
So Stephanie, why don't you tell Michelle who you are, because you don't understand why I just did that.
Yeah, sure. So Michelle, I work with West Virginia, Indiana, and Ohio. I'm the Narcan lady for those 3 states. So the company that manufactures and sells Narcan nasal spray, the 4 milligram strength, I'm the director of community health solutions for those 3 states. And so my job is really to help everybody who needs it have access, especially somebody like you who's doing on the ground work in harm reduction. So I've worked with, I've been in Huntington, I've worked with some other entities there, but not yours. So apologize that we haven't met, but would love to connect with you and talk offline.
That sounds good to me.
All right. And Stephanie, you probably also want to know Dr. Reedy over in, they just opened up a new site in Morgan County, and they have a site at the Berkeley Springs Health Department as well. So I'd like for you two to connect as well. Angie Gray does a lot of their harm reduction work over there.
Awesome.
All right. That's my good deed for the day. And so, hey, Tom, do you host like I don't know, like a health department providers meeting? I know that that's usually like NACHO and ASTO type work, but do you do that? Like, do you host like a meeting with the health departments?
We do not. I mean, we will host meetings of our grantees, some of whom are health departments, but we don't. We go to meetings where they're located, whether it's NACHO or a lot of times the National Health Association is, we do a lot of their meetings, but we don't convene.
Right. So, Sean, what's next up for you guys? So you've got this big idea. Now what?
So we do a lot of convenings. So at the O'Neill Institute, again, we're based at the Law Center. We see our role as kind of being at the intersection of kind of law and public health. And so within our infectious disease initiatives, which is where I work doing my HIV work, my boss, who was a former director of the Office of National AIDS Policy at the White House, Jeff Crowley.
Name dropper.
Yes, I mean, but they come more for his relationships than for me. But he has very close relationships with folks across the federal government, also state and local health departments and community-based organizations. So we do convene different entities to kind of come together to talk about topics. And so kind of, as I mentioned, we just, based off of some convenings we did, we released our telehealth brief. We also released another brief focused on supporting HIV programs through COVID-19 and beyond, focusing on obviously improving the response to COVID-19 and maintaining that response and maintaining funding for not only just for COVID relief funds, so that state and local governments kind of navigate this kind of really tough budgetary environment that they're in right now, but also maintaining the commitment to the Ending the HIV Epidemic initiative and to public health. So having discretionary funds for public health, but also addressing equity issues as well. So those are two things we've most recently released. Going forward, we're going to be obviously looking at opportunities within the current the new administration, the Biden administration that'll be coming in. What are things we can be doing to expand healthcare access? So again, expanding the Affordable Care Act, but also making sure that we make the right adjustments for particular populations. So within Medicare, making sure that we're addressing the needs of older folks living with HIV within Medicare and preparing the Medicare program for that. Thinking about Medicaid expansion opportunities and other ways to meet the needs of people living with HIV. So that's going to be obviously a big focus of everyone, but something we're working on. And then we're also doing some work around vaccine. So the COVID vaccine and how we can start a lot of these conversations, well, continues. I think some of these conversations are already happening. So there are community discussions, particularly to just make sure people know that the vaccines are going to eventually be there, addressing issues of mistrust. So we know there are a lot of populations that, at least right now, if you were to survey them, they would probably either not take the vaccine or have a lot of hesitations about it. So, and that, includes, not just, Trump supporters, but also like within communities of color, there's a lot of mistrust of kind of medical research. And so we need to have those conversations, and we're working with, partners, and we're going to be continuing to engage with folks to kind of get out materials to kind of support some of that kind of work, particularly among our kind of HIV kind of stakeholders. So what they can be doing now to kind of address some of those knowledge gaps, have those types of convenings, and then start thinking about not only just distribution of COVID vaccines, but again, co-locating of services. So when folks are coming in for the vaccine, making sure that they're getting tested, making sure they're getting referred to PrEP and things like that.
Right. So, I mean, I didn't say this and kind of late in the day to say it, but, I really do think vaccine preparedness is going to be really important and an important piece of work for particularly our local health department. And I say that because, I participated in the Moderna vaccine trial. And I think that the more, and I should have said this earlier on, I don't just play a trial participant on TV. I actually am one. And I think that being able to kind of say that and having people who have either participated in a trial, know people who participated in a trial will be critically important. Because there may be some side effects for people. There may be, you may be tired after, your arm may hurt after, but I don't think that it's a reason to not to participate in a vaccination. And I think that we've got to figure out ways to get, I know that there's I think $300 million that has been spent on this vaccine education media campaign, but it might be a little day late, dollar short if we're already rolling out vaccine at this point. So I think that it's going to be really, really, really important that we think about what are the lessons that we've learned from HIV, social marketing and social networking that we can apply to COVID. And what are the skill sets that we can learn, I think, from PrEP education and PrEP navigation that we can apply to COVID. I think one of the things we did learn from HIV vaccine preparedness was that not having a vaccine truly available impacted people's willingness to participate in a vaccine trial for HIV. But now that we actually have a vaccine for COVID, I think that we can look at social networks, sexual networks, drug sharing networks, and familial networks as a way to communicate the value and importance of vaccination for the short and long term. Is anybody on the call have questions for anybody? Ask your questions now. because Tom's like, whew, I'm gonna go eat my lunch when this is over with. I'm never taking Tony Young's call again. Sean's gonna be like, man, I don't know that Tony Young, Dr. Reedy. Daphne's like, I prepared all those slides and she didn't let me use them. We had time, I could have used those slides.
That's okay. You can hand them out or not hand them out.
Well, we're handing them out. We're handing them out.
Then that's perfectly fine.
All right. They are not going to waste. Sean, is there something you want the people to know before hang on, I just got the question. Is the CDC website the best source to direct the public to, hang on, for understanding the vaccine? Maybe I would also probably send them to the FDA site so people can understand what the process for approval of a vaccine is, because I think that that's where some people are likely to have many questions. And one of my big-headed staff says that they, on our team, says that they have a question for you, Sean. Emma, you have a question for Sean?
Yeah, I was just going to ask you to go into a little bit more detail on what kinds of partner organizations are you working with to deliver education on vaccine preparedness, and what specifically have you guys been talking about? How are you accessing community members directly, or is it more just talking to the partner organizations, coming up with some type of marketing or something?
Yeah, so in terms of, this is work that we're kind of starting out. This is going to be really a major focus starting in January. And again, like vaccine rollout is starting now, but in terms of reaching the general population, we're still really not seeing that happening until the spring at the earliest, and maybe even kind of late May or June, really. So what we're going to be doing, again, we use our role at Georgetown and kind of the directors of our program to convene folks. So we convene diverse stakeholders, usually kind of the way in which a lot of our meetings happen, and Tony's come to a number of them. We get like 30 to 40 people together. We try to keep closer to 30 because we know too many people, it's hard to have like the type of robust discussions that we would like to have. But yeah, we have representatives from the federal government, from state health departments, and then community organizations from across the country. So we work really hard to engage, again, national players that I think a lot of folks would know, folks at places like NASTAD, folks at NACCHO, organizations like that, but also, you know, on the ground community-based organizations. And we try to get representatives from the community there as well. So we try to get a good cross-section. We have a community advisory board that advises all of our projects. And so they help us to identify people. So starting from there, that's the beginning of us kind of having dialogue. We do our own independent research, and we also do follow-up. So we do interviews with folks in different jurisdictions to learn from them, what's going on, what are they already doing, what can we learn that are best practices, and then we kind of formulate our reports. So kind of like the telehealth brief that I circulated, I think it's in the chat, and that might have been previously circulated, that kind of summarizes topics, authors' recommendations, and again, kind of highlights best practices or models that jurisdictions might want to consider. And then we work to get those out to the community-based organizations so that they can then kind of act upon kind of our recommendations and use our kind of evidence-based materials in either their education or their work. So that's kind of our model. We do, I think, get things out pretty broadly. Like, so I would imagine with the work that we're doing on vaccines, we're going to try to get things out for some of the big national conferences, which are mostly happening virally next year. If AIDS Watch happens, it kind of again in some formulation early next year. So we'll get them out to as many stakeholders as possible to start that education process. And a lot of things are already happening, but again, we see some of the best practices that are taking place. We want to get it to everyone so that can go forward everywhere. So.
Right. Thank you, man. I appreciate you. Thank you so much for doing this, Sean. Tom, what do you want the people to know?
Well, just anything we can do to make you aware of our programs and resources to the extent that they help you along the way. We want to do that. So don't hesitate to reach out to us, and look forward to any collaboration we can have.
All right. All right, Daph, other than make sure everybody gets these slides and just play them on our website on a continuous loop, what else, what do you want the people to know?
Well, as it relates to 340B, I think I probably have shared all the most relevant information. And then I guess I should have mentioned this earlier too, but as it relates to telehealth, we were able to really in part because we'd already begun teleprep before the pandemic. So we'd laid some of the foundation. We were pretty successful in moving most of our in-person visits to telehealth. So it can be done, and with infrastructure assistance, that's a a big deal. But our experience has been that our patients report greater satisfaction and fewer no-shows. So if that's helpful, I'm certainly not the person that made that happen, but I can put folks in charge with our chief medical officer and our chief healthcare operations officer if there are any learnings that would be helpful to the group. Thanks for the invitation.
Thank you, and I'm sorry I cut your slides, but I left you a voicemail. I went old school.
You did. I had fair warning. I'm totally okay with it.
All right. And Michelle, what do you want people to take away and know about what's going on with harm reduction down there where you are, and what you might need, what tools you might need?
Well, just know I think all harm reduction programs across the state have had an impact, or the coronavirus has had a significant impact on our ability to do services. We're still trying to do the best we can and never close our doors. Things that we would probably need help with, if you all ever see any grants out there, I had one of my staff do some research for grants that were kind of outside the box, so to speak. They don't have to be, because when she was asking me, well, what do I look for? And I said, just look for just about anything that would fall under public health. I mean, you all know how to do this. I don't have to explain it, but anything that you see, because as much as I'm looking for grants, sometimes I don't see everything, right? So if you all think, hey, Michelle and Cabell could probably apply for this or maybe interested in it. I started looking at Elton John's grants. So anything that I can do to help our program sustain itself, because contrary to popular belief in Cabell County, your tax dollars are not used to fund our program. We've run into that politically. Sometimes I could use some extra help of dealing with, when we have another election come around. That seems to be when we get the heat on our program. So, just little tools like that, things of connecting to people, just things to keep us sustained. That way we can keep our doors open to our population, because if we don't have that connection, then I don't know what's going to happen to our participants. That's one thing that concerns me. When they were coming after the levy, which we don't use, but people in the community were saying we were using levy money to fund this program, so let's shut it down. We made it very clear, if you don't vote for the levy, you're going to be shutting down all the other services, not the needle exchange program. But anything that I can do to try to keep our program sustained is what I need help with. And the health department probably needs people to apply for nursing jobs here pretty soon, because they're counting down the days out there.
Right. I think that staffing and employment in rural health departments is critical. I think especially in a place like West Virginia, where you can make a third more, or sometimes almost 50% more if you go across some border communities. So Dr. Reedy. what do you want the people to know? How can they help you? How can they help public health in the Eastern Panhandle?
Well, I think the biggest thing is being civil to each other, because we're not very far apart. And as we're now seeing, last week we had 1,000 new cases of COVID, and people have suddenly realized, just like substance use disorders, that it affects us all. It's not just those other people that get affected, and trying to work with us. We do not have a levy, so we, we're a pretty small organization, as are most health departments, and I think people becoming more educated themselves on public health and reading a little deeper than just the soundbite they see on Facebook or wherever, because this is mostly about people taking care of their control of their own lives and learning.
All right. Well, at the end of this, I want to thank you all. And I think I'm going to close on a somber note. And that somber note is that we have just passed 300,000 lives lost to COVID. And it's very important to me to frame this in, and I don't want to cry, but to frame this in terms of lives and people. These aren't just cases. These are people, and these are families, and these are communities that are heavily impacted, if not destroyed. And I think, Dr. Reedy, I appreciate what you said, is that, I think it's just, we have to be civil to one another, as well as we have to support one another to get through this. And the vaccine's here, but we've got at least another year of this. And we have to rely on one another. And if y'all tell anybody I cried like this, I'm really gonna deny it. And but man, this is been a rough 2020. 300,000 people. 300,000 people. Lots of families. They don't all look like us. They don't all talk like us, worship like us, but these are Americans, man. We got to do something. And we're in this together. And so I'm going to close on that note. And I want to thank you all for giving me your time today. And I thank you all for participating. Sean, thanks. Maybe we can do like a little public policy training for people like Michelle. Like, here's what you can do at the state level. How to advocate for your issue, or, whatever we need to do.
Yes, to do that, yeah.
Thank you, guys. And I'm sorry I kind of lost my stuff at the end here. But that's a lot of people, man. That's a lot of people.
I'm glad you could express it, because it's bottled up in all of us.
Yeah. All right, everybody have a great holiday. We're gonna rock it out in January. Have a good one.